So a basic question patients ask who have ALS, and their families also, is how does my disease progress? And ultimately, how do I pass away from ALS? ALS is a disorder where weakness progresses, and it generally progresses to involve almost all parts of the body, independent of where it starts. So whether it starts with speech and swallowing, or hand and arm movement, or leg movement, eventually all limbs become weak, and finally, the nerves that go to the diaphragm, the breathing muscle, become weak. And people basically pass away from respiratory insufficiency. Nothing happens quickly in ALS, and everybody seems to have their own rate of progression. And so there's no good evidence that things speed up toward the end, but unfortunately, weakness does progress. But it gives time to plan, and we are going to hear or have heard about palliative care and hospice, and so there are plenty of times to make decisions. A big decision relates to respiratory care and how we can support respiration. So my colleague, Dr. Brown, will answer some of those questions.
I'm a pulmonary and critical care doctor, which means I take care of a lot of patients when they're very ill. And one of the key pieces of feedback I've heard is it's much easier for both the patient and the family if you've had conversations about what kind of care you would want or what kind of care you would not want in the future. One of the opportunities that ALS affords us is that we do know that the disease will progress, so it's important to have those conversations early and with any family members or friends that may want to participate in that. Palliative care can help facilitate some of those conversations and ask about what options you may want or not want.
Certainly sometimes ALS can progress very rapidly, where we're doing many things at the same time. At each visit, there's lots of different things that we would recommend be done urgently. But in most cases, it's a slower progression, and we have time to think ahead and plan for the different pieces of equipment that would be helpful in preventing bad outcomes. And that's really one of our big goals from our ALS clinic, is to help plan and think ahead about what those pieces might be.
So again, palliative care is provided for anybody with a serious illness at any stage of that illness. And it's really meant to address any symptoms related to that, any stressors related to that, to help facilitate care whenever possible, but certainly to talk about goals of care so that at any point during an illness, you're getting exactly the type of care you want and not types of care that you don't want. Really is supporting someone with a serious illness throughout an illness. If you take ALS, for example, symptoms could be shortness of breath, difficulty swallowing, difficulty with ambulation, the stress revolving around having a condition like this. It's really just an extra layer of support and doesn't really determine what kind of treatment is being pursued. Basically, all treatment can be pursued at any time. So in ALS, for example, you could be getting artificial nutrition through a feeding tube. You could be using BiPAP or other ventilation type devices. And the palliative care team would still work with you to try to improve your quality of life and the quality of life of a patient's family.
Then the next question people ask is, what can I do about ALS? First, we don't know exactly the underlying causes of why nerve cells that generate strength degenerate and die in ALS. There are a number of theories, and although we don't know the cause, we have had a large number of drug trials. At this point in time, there are several drugs that have been approved by the Food and Drug Administration to slow the course or the rate of progression of ALS. Unfortunately, no drug is expected to restore strength. So we do have several drugs that slow the rate of progression. So that's one thing, to participate in taking those drugs if you're comfortable with them. The second is that being in a multidisciplinary care clinic has been shown to, in general, prolong survival. And then the third, the most important part, is supporting respiratory function, because that's the ultimate muscle whose weakness causes people to pass away. So if we can support respiratory function, then that helps prolong life. And in fact, someone could maintain their life beyond the natural course of ALS with respiratory support.
Breathing devices, we often recommend ones like BiPAP or cough assist, and really think about those things as kind of paying it forward. Like, the more you use of those things, the better off you're going to be in the long run. That we know when they're used early, they're used correctly, that's one of the best ways you can do to help fight this disease. And so when we talk about fighting or giving up, using these equipments actually is a much better way of fighting than saying, I'm not going to do it, I'm going to do it on my own. And the same thing with a feeding tube, where when you push it to that extreme, then a couple of different possibilities could happen. One, you wouldn't get adequate nutrition and you would lose weight rapidly. That would cause your body to use your muscles as an energy source, and then you would end up being much weaker because you weren't able to keep up that nutrition. Also, when you think about simple things like hydration or pills, those might be things that you would forego that would obviously be really important for your body. And then there's, of course, the risk that you would instead get some of that food or liquid down into your lungs, and then you get very sick because you end up with a pneumonia from it. So lots of different ways that a feeding tube can be really helpful and a very valuable tool. Though one guarantee in ALS is that you will have breathing issues. And so in terms of breathing equipment, we know that everyone will need it. But with other equipment like a feeding tube or a wheelchair, we don't always know. But we do really try to think ahead in our clinic and plan for those possibilities and likelihood as we see progression going. So we want to bring it up before anyone needs it so they know that it's coming. But at the same time, those different pieces of equipment are the best way that we can to help keep people as functional and independent as possible.
Sometimes patients will ask, do I need a tracheostomy at the end of my life with ALS? Only about 5% of patients with ALS elect for a tracheostomy. There can be challenges with tracheostomies with care, speech, and swallowing. They also don't prevent the progression of further muscle weakness. So I have had patients where their weakness progresses to the point where they can't blink their eyes or move their eyes. And so they will have difficulty communicating with caregivers. They require more care from their caregivers with a tracheostomy and being ventilator dependent as well. So again, these are things that people need to think about. We try to use the BiPAP-like devices, also referred as non-invasive ventilation, and this can help sustain people's lives longer. But we also have to recognize that sometimes they can also provide discomfort at times too, depending on the individual patient. And I think it's a balance of being realistic about what the cost of the disease is to you on a day-to-day basis and deciding whether that cost is now too high.
So what's the difference between palliative care and hospice care? That's actually a question that we get a lot. Palliative care is to treat the symptoms and stressors of any serious illness throughout the course of that illness. It's focused on improving the quality of life of patients and their families to really ensure that the treatments that someone is getting during their care is in line with their overall goals for medical care. Hospice care really focuses on the last 6 months of a terminal illness. And during that time, we don't expect recovery, we don't expect to improve, and we start to focus on comfort versus extending or life-prolonging measures. So it is a type of palliative care, but it's really focused on those last 6 months of a terminal illness. It does provide a higher level of support. There's spiritual support, there's social work support, and medical support. So you kind of get a whole team to help guide you through that final process. One part of palliative care that is integral is the ability to really explore someone's goals of care, what type of medical treatments they want, what the big picture is for them throughout the course of their illness. I think in Western medicine, we can often just get on a conveyor belt and sort of get shot through the system. And it's very important for patients and their families, especially with complicated medical conditions, to really understand what options they have and to understand that they have the right to make decisions about what kind of care they want at any point within their illness. A palliative care provider would explore all the different options available and discuss that at length with a patient and their family to make sure that's exactly the type of care they want, whatever they choose. So a palliative care provider would be in addition to your neurologist, and sometimes there can be a team associated with a palliative care provider. It could be just one physician or other type of medical provider, or sometimes there could be social workers or others involved. Hospice care, on the other hand, does have a dedicated team built in with it, and every hospice care provider will have that team because it's sort of dictated by what it means to be a hospice provider. And that includes spiritual care, social work care, some nursing care, some assistance in the home, but the whole team comes together as part of hospice care. As opposed to palliative care, hospice care really focuses on dignity and comfort in the final 6 months of a terminal illness. They help prepare a patient and for family for what's to come and really provide that holistic support to deal with any physical symptoms, any emotional symptoms, any existential symptoms related to fear of dying. All together, it comes as a sort of a package of support. When it comes to hospice care, there's sort of 3 locations that someone can be on hospice. The most common is that someone's on hospice care at home. That means that there has to be someone in the home that can help provide care for the family, even though there is assistance through the hospice company in terms of some nursing, some patient care like bathing and transfers, and then the other services that are provided, but it's not 24/7. Some people will opt to receive hospice care in a facility. The facility is not generally covered by Medicare or Medicaid. However, some people will pay out of pocket because it's too difficult to do at home. In some rare instances, the needs are so acute, they're hospital level, and someone might be in a hospital setting when they receive hospice care. In general, hospice is fully covered by insurance. In many cases, when people don't have the means, hospice companies will also provide that care.
Another important question patients and family ask when the diagnosis is made is, how long do I have? When will I pass away? It's very difficult, if not impossible, to predict accurately in a given patient. And to be frank with you, I don't try to predict. What we do in clinic is try to optimize care. But going back to the answer, how long, we can look statistically, which means taking a large group of ALS patients. And since we never know exactly when the disease starts, we time 0 as when symptoms are recognized. That is, when do you think you had your first symptom? And if we follow patients, a large group of patients, we find that 50% of them will have passed away between 2 and 4 years from symptom onset. It also means that 50% will live longer than the 2 to 4 years. But where an individual patient fits on this curve is very difficult to predict.
So I often ask patients, what are your goals? Sometimes it will be a graduation or a wedding or a specific event in time. Sometimes it's just they want to spend more time with their family. But eventually patients get to a point where their symptom burden, be it shortness of breath, fatigue, muscle weakness, those things get them to a point where they're ready to die. And that is where, and before then, we want to talk with hospice and talk about a plan for making patients comfortable during that actual process. As the respiratory muscles get weak, Often patients are spending more time using their non-invasive support, either their BiPAP or their ventilator, and we want to make sure that they're comfortable during that dying process and that the family is comfortable as well. So the more planning is usually the better.
When people are progressing with ALS and they do become short of breath and they do look more directly ahead, they ask, how will I die from ALS? The most important point is that ALS, you should pass away comfortably. It's not a painful death. You hear about other conditions, for example, cancer, where people are in a lot of pain and their organs are failing and there's a lot of distress associated with it. But in some sense, ALS is a simple disorder in the sense that no other organs are involved. And so the breathing issue is the diaphragm, not the lungs themselves. And so there may be some discomfort in ALS from not being able to move about, all of which can be managed. But the actual passing away is, in our experience, not uncomfortable. Generally, people pass away in their sleep. Occasionally, patients want to know a little more specifically about what's the actual mechanism that causes patients in ALS to pass away. Well, we know some things. We know that when people have been looked at immediately after death, there's a lot of congestion in the lungs. So the breathing slows down, fluids are not cleared, and they're the beginnings of a pneumonia. The second is when people slow down, breathing slows down, they're not moving as much, they're not taking in as much fluid, likely they become relatively dehydrated. Not to the point that they're thirsty, but they become relatively dehydrated. And then the blood probably becomes a little bit thicker. And then since ALS is a disorder of older people, probably a fair percentage have some underlying heart vessel narrowing that's not symptomatic. But when you have the combination of vessel narrowing, reduced oxygenation, reduced blood flow, then likely it's what I would call a cardiopulmonary death. It's not uncommon for family members to ask, what will my loved one look like when they're passing away? What should I expect? Well, first, when I talk to families where someone's passed away, the most common answer is they just fell asleep and didn't wake up. So there really is nothing to see in that regard. Sometimes patients will feel short of breath and a little anxious. And usually this happens a bit earlier on, and then the family and the patient have the opportunity to inform us, and then we give medications to take away that degree of anxiety. Or palliative care and hospice is involved at that point, and they also give these medications that can be given so they immediately relieve any patient distress from shortness of breath. Some of the patient's feeling of shortness of breath is more anxiety than actual gasping for air, and that passes on its own, or the medication can help pass. But for the family, usually they don't see anything that is distressing.
So we often use medications like narcotics. They decrease what we call air hunger or shortness of breath. We also use a class of medications called benzodiazepines, which reduce anxiety and stress. So we give those, typically we start out in smaller amounts, but then we can increase the dose and the frequency of those medications. So often what I hear from my patients' families is that it just looked like the patient went to sleep. Hospice is a service, typically provided in the home. Often there are nurses associated with it that will help to dose both narcotics and benzodiazepines and help family members adjust for patient comfort. Sometimes patients will have a little bit of secretions or mucus. There are medicines that we can give for that as well. But typically you adjust those medications so that the patient isn't feeling any discomfort, and then we can take off the BiPAP mask or disconnect the patient from the ventilator and let them die. In general, I found patients that have been satisfied with their overall care when it comes to transitioning from, more life-sustaining care to goal-directed quality of life, is usually thinking about what matters to them. So is it a vacation? Is it a, time with family? Is it a graduation or a wedding? And, kind of planning around those things. And then planning for sort of what would be like the best case scenario, but then also realizing that it's an imperfect world. And sometimes I've had patients get cold or a flu or pneumonia, and then that time frame shortens from, and that, they progress to death more quickly. So I think it's important to have those conversations again early and often with caregivers and loved ones so that people know what your priorities are.
It's hard to believe that you would ever do or want any of these things. And one of those examples is a feeding tube. And I can tell you no one has ever put that on their wish list. But it is something that in ALS care we really use for many different ways, including helping to prolong people's lives, but also to help give them real good quality of life. Providing nutrition when you are not able to take it yourself is a really important thing. It also gives us a different way of getting medicines in. Instead of having to choke on pills or even potentially in the future placing an IV, it gives us a really easy route. And so when we discuss a feeding tube, it's really another way of helping to provide comfort and really is something that we strongly encourage people to consider. A similar type piece is a wheelchair. And although they're completely different, one being attached to it and the other one not, a wheelchair is another really important piece that, if used properly, can help not only to provide comfort because you're going to be able to sit in the best posture and have cushions underneath you, but also prevent you from a fall and prevent you from trying to get that last little step out when really it's actually that's something that could provide or could cause a lot more harm than if you were to use a wheelchair. Again, it goes back to none of these equipment pieces, none of these things are things that we ever thought that we would want. And sometimes it also seems like we're just piling them on. But these are tools that we've learned from other patients that how helpful these things can be. And it's only our other patients that have taught us really how valuable those pieces are. Those pieces allow you to do more. I know that there is sort of that thought that if I keep working or keep walking on my own versus using something like a cane or a walker, that's going to make me stronger. But the unfortunate reality is at a certain point, that's very untrue, and that's going to make you much weaker because we're going to end up with a fall. We're going to end up in the hospital, broken bones or concussions or other things that we really can prevent and want to prevent.
One of my patients told me that communication was very important to her, and she had lost her ability to speak. And she was using texting in order to communicate with her family and loved ones and us. And she told me very clearly, if I can no longer text, then I don't want aggressive measures and I just want to be made comfortable. That's one example of one person's priorities, but I thought it was very well stated. And I think actually provided quite a bit of peace to her family because they knew what her line in the sand was. And when she was ready to go, she was ready to go and she passed very peacefully.